thank you very much to the Histiocytosis Association and the Association for inviting us to participate in this event. It is always an honor to be able to participate in these activities of the patients' associations, which are important for us. And we always like to collaborate. And we hope that the title will be useful. As we were saying in English, translated into Spanish, is not to share a little bit the vision of the patients. And that is what we will try to focus the session to hopefully help patients to resolve doubts about their disease before presenting the team that we are involved in the management of this disease. We are, Joel and I are both attendings of the pneumology service of the Hospital of the Saints Day and Sant Pau, which is a hospital in the center of Barcelona. It is one of the hospitals of high complexity of Catalonia, of Spain. And we participate and we are members of the unit of minority respiratory diseases, which manages among others this disease which is histiocytosis. So, as I was saying, from the patient's perspective, that is a little bit the dynamic of the session. The first thing I guess as a patient you have an impact when one comes into the office one day, and the doctor tells you that you have a disease that is very difficult to pronounce, and very difficult to understand. No, someone tells me I have Langerhans cell pulmonary osteocytosis. The first thing, as a patient, is to understand that this is a minority disease. And that has an impact because social, even medical. Because these less frequent diseases are more unknown. And that leads to, when I share that I have this disease with my loved ones, with my family members or with the medical team, with my primary care family doctor, or other specialist doctors who take me for some other disease, it is true that many times they do not know what this disease is. And this to the patients, because in a certain way it blocks them. And it scares them because they see that it is something that others do not know about. And that is a lot of uncertainty. To feel that you have something that is unknown. Certainly, because we all have uncertainty. And that's why these diseases always have they must have a special treatment in the health system in order to receive them adequately. And to be able to carry out an adequate follow-up diagnostic process. Having said that, Langerhans cell histiocytosis falls into a group of diseases that we call histiocytosis. And there are many of different types that we are not going to go into today. And this one differs from other histiocytosis because the disease is produced by an infection of cells that have histiocytic characteristics, which have certain characteristics which are called Langerhans, and that is why they are differentiated. They differ from other histiocytosis. As I was saying, it is a disease that is still of unknown theology, which means that we do not know exactly why it occurs, that it can affect all ages. But today, and this is important especially for patients who are listening to us, we are going to focus on pulmonary Langerhans cell histiocytosis, especially in adults, because this manifestation, which occurs centered in the lung, primarily affects the lung, and only in a smaller number of cases it appears in several organs at the same time. So today we will focus on this type of histiocytosis, which is Langerhans cell histiocytosis, which will affect adults, and which will mainly affect the lung, which is the one that gives its name to the disease. And although this is a bit too technical, but just so that we are clear that the cell is a cell that we characterize as dendritic, that what these cells do, so that you understand, is to present to the rest of the immune system the things that we are inhaling, that are appearing in our body, so that our defense cells identify it as a foreign agent, something that they have to defend against or not. They're presenter cells. So these angel cells have certain, special characteristics that, for those who look at the biopsy, for the pathologists who look at the biopsy, they are able to identify them and tell us that it is a histiocytic Langerhans cell disease. Some facts about the disease. We say it is a minority disease because, mind you, that only occurs. It is estimated that there is less than one case per 200,000 inhabitants that is, in an average city, for example, in Spain, in which there are usually 150,000, 200, 1,300, 1,000 inhabitants. Maybe there is a case or two new ones every year. We are talking about very few diagnosed cases. As we were saying, the age of presentation is very variable. But talking about pulmonary Langerhans cell histiocytosis, it usually occurs between the age of 20 and 40 years, relatively young people. It used to be a disease that was associated with men, with gender, with the male sex. But today we know what it is. Its incidence is equal between men and women. And what is very important about this disease, this form of histiocytosis, is that in most cases it is associated with smoking, whether it is smoking, active smoking, or past smoking. And this is very important. And that is why the epidemiology has also changed, and now affects both men and women. Because, as you know, men used to smoke more, as women have introduced this harmful habit. Because the presence of both sexes has been equalized. But this is a very important fact. Tobacco is the initiator. It is a very important risk factor for developing this disease. And the other thing, which is the one that has been described, is that it most often affects people of the white race. How the disease appears. How it presents itself, how I know. Or what symptoms I have when I get this disease, histiocytosis of Langley's cell disease. They have been classically described. 3 in forms of presentation. It is true that many patients appear with respiratory symptoms. That here it must be said that this is a problem of respiratory diseases in general, that many times the symptoms are very common. Among them, most respiratory diseases produce this feeling of shortness of breath, especially on exertion. And also cough, and this is very common. And that is why it can be that when you go to a doctor with these symptoms, she makes me a series of tests and rule out a much more common disease before arriving at this diagnosis. And that also sometimes makes the patient's journey to diagnosis longer in some cases. But it is rare. And more general symptoms such as weight loss, fever, night sweats may appear. But this is not common. Another characteristic presentation of the disease is the occurrence of a spontaneous pneumothorax. A pneumothorax occurs when one of the cysts of the disease you will now see ruptures. Introduce air into the thoracic cavity, and this makes the lung unable to function properly. This is a characteristic form of presentation. And really, when a patient has a spontaneous pneumothorax, the others, the physicians, we always think, or we always rule out that they have these cystic diseases underneath, because it is a common form of presentation. And it is not trivial. There are a lot of patients that are diagnosed asymptomatic, which means that they do not have any symptoms. They are patients who have a chest x-ray because of something else. Because they are going to have surgery of the knee, for example, and they have a preoperative x-ray, and they find these cysts, or these nodules. And that is what leads to the diagnosis. As I said at the beginning, the pulmonary histiocytosis of the cells of the lung. It usually affects only the lung. As you can see, it is described that about 80% of patients only have pulmonary involvement. And when there is involvement, also extrapulmonary. As you see here, the most frequent sites are usually the bone, which are sometimes affected, sometimes the pituitary gland in the form of diabetes insipidus, and also the skin, which is less frequent. In Spain, we, the Catalan group, we carry these minority diseases. These interstitial diseases. We have a group in Catalonia called Grampi. We are a very active group of centers here in Catalonia that we like. We are dedicated to these diseases. And we've been doing it for a few years now. As you can see, we gather the cases from our centers here in Barcelona and evaluated the form of presentation. This is an article we published 10 years ago. And, as you can see, we were able to add 32 cases which, being a minority disease, is not bad. And simply, what I want to reflect in this slide is that, as you can see, yes, our data correlated very well with what was described in the literature. As you can see, for example, the vast majority of patients were smokers or ex-humors. Only one patient that we included in the series had not smoked. Many of them had had a symptom onset with coughing, or with dyspnea, but also, as you see, a casual finding 10%, or a pneumothorax, 13%, and sorry I skipped up here the age. As you see, also correlated with what was described before, not between around 38 years old on average. And as you see we also said before, were practically the same for men as for women. And why does a doctor suspect that I have histiocytosis? Because in this study, as we say, if it is because of a pneumothorax, or because I have a YYY cough, this sensation of shortness of breath, and the doctor makes me some initial explorations, and a lot of times they don't. There is no obvious diagnosis of other diseases. More frequent is nowadays a tool for us. It is fundamental to advance the diagnosis of diseases is the TAC, the high-resolution TAC. Okay, it is a disease. It's a tool that we use to further the diagnosis. And there is one positive thing about this disease, is that it has a presentation that is very well described radiologically. So that when the radiologist sees a series of lesions that we will now see, raises the suspicion about this diagnosis. Because pulmonary, cellular and Langerhans disease has what we call this triad, which is that in a high-resolution CT scan these images appear. That you can see these cysts, which are these rounded lesions, which are hypodense images, that is to say, that you can see inside. You can see that there is only air, and they are surrounded by this membrane, which is this white line around them. As you see, all these cysts, that is one of the typical manifestations of the disease. You also see these nodules, which are these whiter images that you see here, which are of increased density of agreement, which is also very typical of the disease. And those nodules, sometimes like this one, here are cavitated, which means that a small hole appears inside. Well, this triad associated with the fact that in the bases, in the lower parts of the lung, are not affected, or, that is, the upper parts are characteristically more affected. This is typical of what we see in patients with Langham cell pulmonary histiocytosis, and it is very characteristic of the disease. And why this occurs? This is very technical, but I just want to say, I want to show this because I think it's important to understand what's going on inside my lung. Why I get these cysts. Which I guess is what you as patient one are wondering. Well, because when, and here we can know. This is a very nice picture from a scientific article. And simply what I want to say is that I want you to understand that at the beginning. What is going on around the bronchus, which are those tubes that carry, not the air, into our lungs? What happens is that an inflammation forms around those bronchi, which is this granuloma that we say. Because it looks like a granuloma. It's really all a very dense picture of inflammation that will be full of Langerhans cells. All right, and that will evolve. That this dense lesion will cause cavitation, which is the next image that we see of these cavitated nodules. And it will scar around the bronchus. And that is why it produces that cystic image. This is the evolution that leads to the production of these cysts from that initial inflammatory lesion to a more scarring lesion. And if I have a CAT scan, and they suspect that I have an histiocytosis, what tests will they do to diagnose? Because we do the diagnostic tests for really what we use the most. They are related to a test that we call bronchoscopy, which is a respiratory endoscopy that, as you see here on the right, consists of a patient who is sedated, introducing a camera through. Not a tube that carries a camera that allows us to go inside the lungs here, explore them, and do different techniques. One technique is bank lavage, which consists of putting physiological saline solution, with which we clean, wash. We do not pass. We take all the material that is inside the alveoli. We aspirate it and we can analyze it. This is a test that has a limited yield. It is to say, it's not very high percentages that we diagnose with it, but it is a test that has been classically used. Because if we found one, there is something characteristic, which is the CD1A, which is a marker that appears in the cells. We could diagnose the disease. A further way is through this endoscope itself. We pass a catheter that carries one that allows us to do a biopsy, and this is another way to diagnose the disease. These biopsies done through the bronchoscope are smaller. And so that's also why they don't have. Sometimes the yield is very low. And it is not usually done. And what is usually done when you have a lot of doubts is to do a surgical biopsy, which is, let's say, the test that has always been used as diagnostic, which consists of an iron operating room. And nowadays, through cameras. So, I agreed to take a small piece of lung to be able to diagnose myself. I put this as an anecdote, because that was the reason for this talk. Or contacting the Histiocytosis Association. It was this article that we published last year in an international research journal. Because we have been working for some time on trying to find other markers of the disease that would allow us to diagnose it without having to go to more invasive tests. This study is somewhat preliminary, but I certainly think it is something that the trend is towards. In all the centers is to try to simplify the diagnostic algorithm by simplifying the tests. Then when the diagnosis of the disease is established. So, if we want to have a definitive diagnosis, 100% of the disease, we need to have tissue that shows that we have this inflammation produced by this infiltration by Langerhans cells. But you have to understand that there are times when doctors do not ask for that biopsy, or even get to that diagnostic test because, as we will see here in a proper context, is, say a patient who is young, who is a smoker, who has those typical findings in the CT scan, and who has and who does not have a great functional affectation that at a certain moment you do not consider at the moment to start treatment beyond quitting smoking. Many times we are left with a diagnosis that we say is presumptive, and we do not request a biopsy, because the biopsy has its risks. Going to an operating room. So we have to understand that sometimes the doctor may not ask me for a biopsy. So we have to understand that sometimes the doctor may not ask me for a biopsy. So we have to understand that sometimes the doctor may not ask me for a biopsy. And if the picture is consistent with the disease, that is enough to manage the patient accordingly. What is true is that all the clinical guidelines recommend that if the patients are going to receive treatment, above all, therefore chemotherapy, other more serious treatments should have a definitive diagnosis. And I am simply mentioning this so that you are also clear when we diagnose a patient. The other thing that we always look at from the clinical point of view is to know if histiocytosis affects only one organ, several organs, because that can also change the treatment that we will propose to the patient. What treatments can you offer if I am diagnosed with pulmonary Langerhans cell histiocytosis? Because if they are active smokers, they will insist. What we will insist more is that they stop smoking. And this is a message that I want to say because it is very clear. And there is very recent evidence that shows that quitting smoking has an impact on the evolution of the disease. That is why it is pivotal, fundamental to stop smoking. There are no excuses. If we don't quit smoking, we have much less chance of slowing down the progression of the disease. Okay, so that's why we insist. And we will insist so much on this smoking thing. In the past, corticosteroids were widely used in patients with these diseases, which is a treatment that, at respiratory level, in inflammatory diseases, has been frequently used. However, today it is a treatment that is often not recommended because there are no studies that demonstrate its efficacy. And they are treatments that have side effects. So there is no indication for corticosteroid treatment in this disease. What is done in cases where the disease is very important? Where there is an important loss of respiratory functional capacity, or it is demonstrated that the patient is losing pulmonary capacity despite smoking cessation. As we were saying, what is recommended today is treatment with chemotherapy. Previously, a treatment called vinblastine has been used, and nowadays it is probable that it has. We have this progressive pulmonary ichthyosis. We are oriented to take a drug that is called vinblastine, and in very advanced diseases, because we always have to consider lung transplantation, as I put here below. It is very important to always remember that not all of us have to be treated, that not every patient has to be treated, that my doctor may not offer me a treatment, because it is necessary to individualize, and always depending on the evolution and severity of the disease. That is to say, if I have a very mild disease that I have been under control, and I have been, and that initially, and I do not have any progression, no progression or loss, only with the lifting of tobacco would be enough. And we have to remember also that there is little knowledge about these drugs, because in the end, as it is a minority disease, we do not have so many patients treated, nor are there so many clinical trials with these diseases. How the disease evolves, because it is a disease that is a disease that in general has a good prognosis, although it is true that when we are diagnosed at the beginning, and we go to the middle, we tell you how it is going to go. How is it going to go? How is it going to be? Well, it is difficult to tell the patient exactly how it will evolve, because we don't have good markers of that evolution. But it is true that today we know that the percentage of patients who evolve badly is very small, especially if they stop smoking. So the initial message would be positive. There are even patients, as I put here, that these cysts, these nodules, can be resolved if they quit, if they stop smoking spontaneously. The problem with the disease is that sometimes complications appear, such as pulmonary hypertension, which we will talk about later, and especially in those who continue smoking. As with all smokers, lung cancer can always be a complication. But I understand that as a patient, the main question I will ask myself is, but why did this happen to me? Why me? Because I know a lot of people who smoke, or have smoked, and this has not happened to them. Sorry, then why does this one appear at the end? As we were saying, this infiltration? That is the big question that we have not asked for many years. There has always been a discussion in the medical field as to whether this was a more inflammatory process associated with tobacco, and it is a reaction between tobacco products, or whether this was more like some sort of a neoclassical proliferative process, but of low malignancy, low intensity. There has always been this discussion. And there were studies for and studies against. Not talking, as I say, of the pulmonary history of Langerhans cells. If this is a debate that was always there, what has happened in the last few years? We have learned about Langerhans cell histiocytosis. That we know that there are a series of alterations in a pathway called LAMPK, which is a signaling pathway. So that you understand how the cells are regulated, how they grow, how they survive over time, how they proliferate, because we know this happens. This was initially discovered in Langerhans cell histiocytosis, that these patients had a very high percentage of patients, some mutation in that pathway. That you see here, the first one that was discovered was the BRAF, which is a mutation that is also present in other types of diseases. And this was also found to occur in histiocytosis. Later it was found that pulmonary Langerhans cell histiocytosis alterations in this mutational pathway were also present. However, although we know that many of our patients have this mutation, and this has allowed us to advance our understanding of the disease, we also have to say that it does not really explain everything that happens to patients. Because we know that, regardless of the presence or not of this mutation, the behavior of the disease may be different. It is. I mean, just because I have this mutation doesn't mean that I'm going to do worse, or it's going to go better. It seems like this is part of the disease. But there must be something else that we are not yet able to explain. And this is frequent. It is frequent that there are these mutations, as you can see. For example, talking about Langerhans cell histiocytosis. Well, you see, many patients have some mutation. The vast majority have mutation in this pathway. And this is very important because some of these mutations that have been observed, they have some treatments that block that mutation. So we have another alternative to treat these patients. What happens is that we know little about this treatment of this blocking these pathways. In patients with pulmonary Langerhans cell histiocytosis, there are cases described in the literature that have been treated with one of these treatments and have been effective. But it is true that they are generally rescue cases, that is to say, when other therapies have not worked, then, nowadays, what is done is, that is an alternative. That is there, but it may be that most of the cases to you might not even look at it, or not offered as a great initial treatment, because generally, as I insist, you have to look at the behavior of the disease. And if it progresses, it may be that the first thing that is recommended is chemotherapy. And then, if not in any case this treatment, in this subject, to an incidental uncertainty about the indication of these drugs. And we also carried out a study in Catalonia, in which we led it from the Hospital de Sant Pau, but also in the hospital where they participated, in the Hospital de Vall d'Hebron de Bellvitge, the Hospital Clínic de Barcelona, in a project that was founded in that by which it was funded by the Foundation of the Buda Madrileña and by the Spanish Society of Pneumology. And we also made collaboration with the Carlos III Health Institute of Spain. in which we looked at the presence of the Langerhans cell mutation in patients with pulmonary histiocytosis. In our case, in these patients we looked at, it is true that our R percentage was around 40%, that is, a little bit lower than described in other series. But it is also true that it depends on the patients that are included. Because you include patients with more inflammation, it is probably easier to observe the mutation there. But in any case, the message would be that really these mutations, as we see if they are present, not in also in patients with Langerhans cell pulmonary histiocytosis. But as I say, when, for example, our series we look at this mutation, we didn't see that the patients had a worse AVR or more aggressive AVR. So, concluding, I think it is important to emphasize the positive things that we already know about the disease, such as the role of tobacco. The fact of the progress we have made with chest CT is also positive, which allows us to diagnose or suspect the disease. It is also very important the advances that have been made in this field in the last 10 years in terms of knowledge of the disease, which have opened up new therapeutic avenues. But I believe that, as a patient, there are still many needs to be covered. One is that we have to continue to deepen our knowledge of the disease. Why it happens to me. It is something we still have to keep working on. We have to get diagnostic tests that are simpler for patients, and that have a better diagnostic yield. That is, that simplify the process. We need markers that do not. When we diagnose the patient, we can tell you if this is going to go well, or it's going to go worse, so that the patient can also have more peace of mind. Because if not, it is often with that uncertainty that we always come to the visits. And we need effective treatments with less side effects. And with this I finish by thanking us. We have been doing research on this disease for many years, and working with Sylvia Beryl, who is a colleague who is now in another hospital in Catalonia. Her doctoral thesis was about YY Histiocytosis, also Dr. Sonsoles Hortelano and Javier Alonso, from the Carlos Tercero Institute in Madrid, who have helped us. And, as I say, we have been working on this disease for years. What has it been like for us?
Con la ilusión de contribuir y dar nuestro granito.
And we continue with the illusion of contributing to the and do our bit. Always thinking about the improvement of patients. And without further ado, thank you very much, and I give way to Joel.
Hello, very good afternoon. Thank you, Diego, for the kindness of the passage of the session. Before we start, I wanted to thank the organization, to thank Fernando and Peter for the kind invitation to participate. No, as already mentioned, Diego, this is always with the objective of being able to provide a little bit of information, not in this type of diseases, that sometimes, well, they're within what is a minority diseases, and that sometimes have a background that is a little bit darker. Because no, there is not a sufficient volume of patients. And so it generates more uncertainty than certainty. If our intention is, well, to try to clarify a little bit. Well, as has already been mentioned, my name is Joel Francesqui. I am a pulmonologist at the Respiratory Minority Diseases Unit of the Holy Greek Hospital and Sant Pau Hospital in Barcelona. I work together with the other Diego Castillo. Well, nothing to go straight to the point. What my colleagues have commented is a brief introduction, simply as a reminder, of the history of Langerhans cell lung disease, also known by other names, such as eosinophilic granuloma, or the classic histiocytosis X, are not older names that were used for this type of disease. And, as already mentioned, Dr. Castillo, because this is a disease caused by myeloid precursors that infiltrate various organs. In our particular case, we focus on pulmonary infiltration of this type of cells. As you already said also, because there is most of the patients have a history of previous smoking, or active smoking, which nowadays has come to be considered as a causal factor. Beyond the association itself, it is considered to be a causal factor of this type of involvement, of this type of pulmonary histiocytosis in the characteristic cells, because they are dendritic cells, which you have already mentioned, that are very similar to the Langerhans cells present in the skin. It is just that unlike these specific cells that infiltrate the lung, because they are cells that express protein CD1, or protein S100. No, they are, and they cluster characteristically around the airways of the airways. I think it's not redundant, but it is important to repeat the high association that exists with tobacco. This association is almost universal in patients with pulmonary Langerhans cell histiocytosis. Active tobacco use, as it promotes the accumulation and maintenance of this type of dendritic cells that are the cause of the disease. And, as already mentioned, as smoking cessation can lead to spontaneous regression of the disease. However, it is important to know that there are profiles of patients who may have a progressive disease. That, despite smoking cessation, the disease may continue to progress towards chronic respiratory failure, or with complications such as pulmonary hypertension, which is what we are not aiming at. What my talk is aimed at, what is pulmonary hypertension? What we understand, so we are not quite adequate to hear the terms hypertension. Arterial hypertension, not the classic one that we measure with the sphygmomanometer on the arm. No, however, pulmonary hypertension is a little bit more specific term than what it reflects. It is the increase in blood pressure within the pulmonary vasculature. It's a little more complex to understand, but it is true that there are several mechanisms that generate an increase in the resistance of the pulmonary vasculature. Of the pulmonary vascular resistances, no. The increase in the pressure of the blood that reaches the lungs? No. And this normally, it is the result of a narrowing of the arteries. It is a disease that makes a somewhat unfortunate connection between what is the lung and the heart. It is not a disease in which, because the blood vessels that go to the lung, which bring the blood directly from the right chambers of the heart, increase the pressure of these vessels in the lung, generating in a retrograde way a dysfunction at the level of the cardiac right chambers. The classification of pulmonary hypertension has a hemodynamic classification, a slightly more complex classification, based on parameters that we measure by means of slightly invasive techniques. As of today, the diagnosis is considered when there is a mean pulmonary artery pressure greater than 20 of mercury with a pulmonary vascular resistance greater than 2 Wood units. This is a bit complex to understand at the patient level. But these are the terms that we use and the values that we use as reference to be able to establish the diagnosis of a pulmonary hypertension, and these are the data that are maintained and are derived from the international consensus guidelines of the European Society of Cardiology and the European Society of Respiratory Medicine. And how we make this measurement, how we come to diagnose it. So the gold standard or the test. Let's say this, the test indicated for the diagnosis of pulmonary hypertension is right heart catheterization. Cardiac catheterization. It sounds very much like the techniques used in patients who suffer an acute myocardial infarction. However, in acute myocardial infarction, a catheterization is performed to open an artery in the left chambers of the heart. In some cases also in the right chambers of the heart. But in the case of right heart catheterization, it is a diagnostic, ethnotherapeutic technique. That what it does is to measure the pressures inside the right chambers of the heart, which are those that are closely related to the increase in pressure of the pulmonary blood vessels, which is what defines pulmonary hypertension. Normally, this test is performed under all safe conditions. Being an invasive test, it is performed in a hemodynamics laboratory. It is mostly performed by cardiologists. There are also colleagues of pulmonologists who are dedicated to perform this test. And it basically consists of the introduction of a Swung-Ars catheter. This catheter is a long catheter that is inserted through a peripheral vein. It can already be in the arm, or through the neck, and which has a series of components that allow to measure the pressures inside the right cavities, and inside the artery, inside the pulmonary artery, and plot them as the image we see here at the bottom left of the screen. No, it allows us to extract the data of the pressures of the right cavities and pulmonary cavities. With this we get to make the diagnosis of pulmonary hypertension. And in the field that touches us, which is that of Langerhans cell histiocytosis, being a complication in many cases, let's say, late complication of the disease, and not having a sufficient casuistry, the mechanisms involved in the generation of this pulmonary hypertension are not well defined. For this reason, within the clinical classification of pulmonary hypertension, Langerhans cell histiocytosis is classified in group 5, within pulmonary hypertension with multifactorial mechanisms are not fully elucidated, and within the subgroup of systemic diseases, the association of pulmonary hypertension. Pulmonary hypertension associated with Langerhans cell histiocytosis. Because as we have already mentioned, this is the focus of our talk. It is a disease. It is a common complication. Severe complication of histiocytosis. A prevalence of up to 41% is seen, depending on the series in which it is studied and the time of evolution in which the patient is evaluated. Patients with much more advanced disease will have a higher prevalence of this condition than patients in early stages of the disease, pulmonary hypertension. As already mentioned, associated with histiocytosis is within group 5 for the various mechanisms. Very succinctly, We should know that it involves mechanisms associated with idiopathic pulmonary arterial hypertension. Let's say the one that is the main one. And the most common that we have, not the group 1. But it also overlaps mechanisms of pulmonary hypertension associated with interstitial diseases, derived, therefore, from this fibrosis that produces the progression of cystic lesions in the lung. However, there are also other intrinsic mechanisms of involvement, in which, therefore, these dendritic cells also infiltrate the pulmonary musculature, which, therefore, remains. It is totally independent of the involvement derived from the fibrosis, from the parenchyma, or of the pulmonary structure, thus generating a direct damage on the pulmonary vascular, which makes it a little more complex. Is this disease? No, and makes it a little bit more difficult to understand what are the mechanisms and the therapeutic objectives to which we should address ourselves when we are facing this type of complications. The clinical manifestations of pulmonary hypertension associated with histiocytosis. In other words, Langer's disease. Basically, they are those already mentioned by Dr. Castillo, those related to the disease itself, not to shortness of breath, and in many cases cough. However, when pulmonary hypertension is already present, the most striking things are usually exercise intolerance with a real ventilatory limitation derived from the progression of the pulmonary disease itself, or a cardiocirculatory limitation derived from cardiac involvement due to elevated pulmonary vessel pressures. There may also be chest pain. Or there may be signs of chronic right heart failure, increased volume of the extremities, fluid congestion at the pulmonary level, pleural effusions or pericardial effusions. When we want to diagnose pulmonary hypertension associated with histiocytosis, we use different techniques, different complementary techniques, as already mentioned by the other Castle. Because we have the pulmonary computed axial tomography, mainly the high-resolution tomography. However, when we are in the field of evaluating a patient with suspected pulmonary hypertension, we have to take into account that sometimes we will need to repeat the CT scan. And, in this case, we will need a CT scan with contrast to evaluate that there are no other causes that could explain this increase in pulmonary pressure, such as thrombi within the arteries, and for that it is necessary to do a tomography. In this case, with contrast, we also have the complementary exploration techniques of pulmonary function, spirometry, the measurement of pulmonary volumes and the diffusion capacity of carbon monoxide in the lungs. Then the test of suspicion that will lead us to raise the suspicion of pulmonary hypertension is echocardiography, in which we will evaluate data derived from the right chambers of the heart. As I mentioned at the beginning, that it is the right chambers that are intimately related to the pulmonary vasculature, which is affected in pulmonary hypertension. We can also perform cardiopulmonary stress tests, in which we measure parameters derived from oxygen consumption and carbon dioxide production, which allows us to estimate the severity of both respiratory and cardiocirculatory impairment. And finally, the test I mentioned earlier. Let's say the standard diagnostic call, which is cardiac catheterization, which we perform in a hemodynamics laboratory when we have these cases of pulmonary hypertension associated with a Langella cellular history, since they are complex cases. No, not very frequent, because we have to take them to a committee. We don't have time for this. At least in our center, since it is a high-resolution center. We have an interstitial disease committee. And we also have a pulmonary hypertension committee. Here what we do is discuss selected cases with difficult diagnoses. Diagnoses that are not quite clear, okay. And in which, we assess the need for complementary explorations, of realizing some other type of test, or even treatment options. We are sorry about the treatment options. I like to put this slide up, because sometimes, all the previous explanation comes up. It seems a little bit obscure? No. Or, we are defining what the disease is, how it gets complicated, how we diagnose it. And everything seems, therefore, negative. However, I like this image of the slide very much, because it shows you a light at the end of this pure road. And this light is the treatment options. It would be very sad if everything remained dark, and we have no options. Science is advancing, and more. We have more and more treatment options, and the main thing is that and the most important thing when we are in front of this type of complications is to refer to 1. Patients to a specialized care center with experience in treating both pulmonary hypertension and advanced pulmonary disease. Apart from using the usual supportive measures in respiratory diseases, such as the use of oxygen or the use of diuretics in the case of pulmonary hypertension, patients should be referred to a specialized care center with experience in treating both pulmonary hypertension and advanced pulmonary diseases. We must emphasize the importance of smoking cessation, even in the presence of pulmonary hypertension, although we are dealing with a more advanced stage of the disease. And spontaneous regression is much more complicated. What is achieved is a stabilization of the disease itself. And that is why we place great emphasis on the cessation of tobacco consumption. Then we have the treatment options already mentioned by Dr. Castillo. Not corticosteroids, with less and less evidence. Antifibrotic agents, which also have little evidence. Targeted therapies, such as calibrebrin, no. And in the case of pulmonary hypertension, specific for this, which we will see below. Without neglecting the possibility of pulmonary transplantation. When we talk about our specific medications for pulmonary hypertension, we must be aware that, as pulmonary hypertension is a minority disease with a low representation in terms of patient volume. Let's say the data, because they are limited and are basically extrapolated from case series or retrospective cuts? No, we do not have large populations where clinical trials have been developed with this type of drugs. However, from the pool of treatments for pulmonary hypertension, generically, there are 3 that we can use in cases of associated pulmonary hypertension and histiocytosis. One are the receptors, the endothelin receptor antagonists, at the head of which is the best known, the most common, moxatentin, which is very commonly used today. Others are phosphodiesterase 5 inhibitors, and among them sildenafil, and tadalafil, and others are the prostanoids, which may well be intravenous or inhaled. Hypoprostanol, hiloproso, treprocinol. Of these drugs, the most commonly used, with which there is the best experience, and which allows a safety both in terms of treatment and avoiding undesirable adverse effects. It is usually the phosphosterase individuals, such as sildenafil or tadalafil, are the ones that have shown the best response when used in this type of patient. However, these drugs are medications of use from off-label use. No, there is no indication because they have not been tested in specific clinical trials for this type of disease. We extrapolate them from idiopathic pulmonary hypertension, and it has been seen that there are adequate results, and with a good tolerance for the same. And, finally, we should not fail to mention the alternative of lung transplantation. No, this is a highly spatialized procedure that involves the replacement of one or of the 2 lungs affected by the disease, with healthy lungs, usually from a deceased donor. This is a treatment option for patients with advanced progressive disease who do not respond to medications and the usual treatments, and who do not have a contraindication to the patient's prognosis. The prognosis of patients going for lung transplantation does not differ from that of other interstitial diseases, and is quite good. The survival rate can be greater than 75% in the first year. And at 5 years there is a greater than 50% survival, which is 111. Pretty good expectation for patients who undergo this procedure. And, finally, leave a few messages that can be left as a conclusion. Not knowing that Langerhans cell ichthyosis is a rare disease, and highly related to and not causative of tobacco. Pulmonary hypertension associated with histiocytosis is a frequent complication. And importantly, it can have an impact on the quality of life and prognosis of the disease, with limitation on exertion or exercise being the most common manifestation when pulmonary hypertension is present. The diagnostic test to know if we have pulmonary hypertension, in this case associated with histiocytosis, is right heart catheterization, which I have already mentioned, as well as the characteristics of how it is performed, being to this day the one that is maintained as, let's say, the cornerstone, the treatment, smoking cessation. Also to know that we have specific pulmonary vasodilators that can be safe and useful in treating pulmonary hypertension associated with histiocytosis. Among them what? As I mentioned, sildenafil, and always keep in mind the option of lung transplantation for selected refractory cases, and that do not have contraindications. Thank you all very much for your attention.
I just want to pop up if anyone has any questions.
Actually, I have a few, Peter.
Yes, Fernando, kick us off.
Well, I'm going to make them in Spanish. The questions because as the language that was selected is Spanish, so that they all have translation. Well, it is for both the questions. I'm going to ask questions from patients that they passed me. That were passed to me by WhatsApp. Question: if the pulmonary isthio usually has or not neurological sequelae, that is, we check with the adult patients, these that have to be infected, or who have pulmonary involvement, whether they need to be followed up neurologically or not. This is a good question. I taught in the presentation. The clinical guidelines. Because this is the question. No, if I diagnose somebody with pulmonary Langerhans cell histiocytosis, I have to do an extension study. Not until I don't. What other tests do I have to look like to see if they have involvement that in other organs? Here they send two things. One is the symptomatology, that is, to say, there are a series of questions that you have to ask the patients, for example, the skin issue. If they have skin lesions, you have to ask about symptoms that are typical of what I mentioned in the presentation, which is diabetes insipidus. Which is if they drink a lot of water. If they have alterations not in their diet. Which can also lead you to certain symptoms. And then the issue of the bone lesions, because also, as you have seen in the series, even ours, also Spanish, was the most frequent in the bone. Many of these patients are asymptomatic, with which here the symptoms do not guide you. The recommendations of for example, the Eurobestionet. What it does recommend is that you screen for the pituitary issue of diabetes insipidus. Is that it's the pituitary of not an area of our brain. Which is where a lot of hormonal issues are regulated. And then in the histiocytosis it is characteristic that sometimes that gland is also infiltrated. No, and then that produces hormonal alterations. So it clearly has a very clear manifestation. It is this diabetes insipidus thing, which is easy to ask about and to study. So the answer would be, yes, that a patient who has cellular histiocytosis would have to be asked a series of clinical questions to see if he has any symptoms. Not that it correlates. Probably, even if he did not have any. Some study could be done to see if there really are any signs that the blood test tells us that there might be diabetes. And in any case the test is a brain magnetic resonance imaging according to that of the bones. There are people who also ask for an X-ray of the long bones. Because it tends to affect the especially the legs. So that they understand it. Not the arms, then that is usually done. Some people ask for one. There are some tests that show you a scintigraphy. They show you all the bones. And see if there is any affectation. It would be another alternative according to. Well, in any case, then that follow-up. I understand that it is done by who else? An internal physician, an oncologist, everybody. All that follow-up to the patients who would be the best? This, as you know. Or who would be the best? The problem of histiocytosis, if you know it very well, it is that this goes very much by fields. And by areas it does not. In Langerhans cell histiocytosis, let's say non-pulmonary and such, hematologists have always been, at least in our country, the people who have not been involved the most. There have also been oncologists, but many are hematologists. Not in pulmonary history. It is true that the pulmonologist has often been the one who has led all this. But it also depends on his knowledge. So, as you say, if it is a pneumologist who does not have so much knowledge, he will probably send him. Or to an internist, or to one hematologist to do a little bit the one who is the leader. Or the one that takes a little bit of the disease. Well, unless I'm going to questions there in the chat, I'm going to continue with doing shocks. I have them written down here. I didn't mean to put them well in writing. About the registry, patient registry. I know you guys I think have not a registry at the pulmonary his level. But that only captures pulmonary cystitis, right? Those with pulmonary involvement. Yes, it does. You suggest that people also look for ways to register their case. And it is not pulmonary. Or that steam by the taste of each one. Nor, because there is also this record, which was recently launched from the Hospital of Belvica, more referred to internal medicine. Not that which is being led by Xavier Solange. But which refers to all histiocytosis in general, not necessarily to non-pulmonary histiocytosis. Yes, we, the Spanish Society of Pneumology, a few years ago reached an agreement with the Institute of Health, Carlos Tercero, which you know has a registry of respiratory diseases. In Spain there is a registry of minority diseases. Sorry, in Spain there was a project many years ago to register all the minority diseases, which is also a project. Which was, if I'm not mistaken, founded from Europe with funding. So the Spanish Society more than created its own registry. What he said is good. We help you to complete your own registry. To promote it, to put it in a way, then, of course, we, being pulmonologists, what we did was to promote the registry of lung diseases, of lung cells. But this registry is open to any patient who wants to register any minority disease. Okay. Is it true that what happens with the registries? There were a few years when we were registering a lot. And we encourage it. But it is true that, as with registries, sometimes it is also very difficult to implement it because the patient's consent is lacking. No, then the advantage of the one that Carlos had. Third is that the patient himself can self-incorporate, can join the registry. There is no need for any physician to do it. That was an advantage. But it is true that the registers have this issue of having to be completed with clinical data that many times doctors do not have the time to fill in those registries. But the answer would be yes, it is an open registry. It's a registry that patients can be included. That if it is in Spain, I would recommend you to be included in that open registry. And that is commented by Carlos Tercero. But I think that, apart from the registers, what we need are directed studies. You know, studies that solve questions, because sometimes registries are very good to know the casuistry. No, you know how many cases there are in Spain. But I think we also need studies, not only in Spain, but in Europe, in the whole world. We need studies that are aimed at resolving questions. Because that is probably also more useful for the patients, or that is, the registries should not only help us to know how many cases there are, but they also have to help patients to resolve questions. Yeah, this practically ties in with the last one I'm going to ask you, is that of course who is, let's say, the think tank that thinks about all these things in a sense. Is there in Spain any group, for example, that for adults talks about histiocytosis? If you want to solve certain cases that patients find themselves in. Or is it really each center by itself? How far it can go? That is, to say. Of course, you're talking about, obviously, the College of Pulmonologists. But, of course, that's a portion of it. Yes. As you say, the vast majority, for example, is in bone, in skin. No, there are a lot of lesions, it is. Yes. That is, there is contact between those branches. Yes. Or is it really so scattered that there is not yet something general, as there is more on the pediatric side? Yes. No, that seems to be a little more organized from that place. Or that there are more referent figures, no. Yes, I have to tell you that in the field when we started with this histiocytosis. Because I started to coordinate this within the Spanish Society of Pneumology and the Catalan group. I have to tell you that we did have with pediatrics. With ITCR we had a lot. Not with who they are. With pediatrics reference, we had a lot of relationship. In fact, they help us. And they helped us to participate in things. And to get involved in projects. And we have had contact at the Spanish level. And what has always been more difficult for me is the contact with adults, with other specialties, with reference from other specialties. Sometimes there were patients who contacted us because they had histiocytosis. And they saw our name. And they contacted us, but it was a histiocytosis that was not pulmonary. Or that was not the main problem. And it was difficult for us to find a referral to send the patient to other autonomous communities. You know why, with and with the pediatricians. Okay. Sometimes they were the ones who had to help us. So I would tell you that with pediatrics there has been a good relationship. And there has been communication. I would say that there is probably a lack of reference. I think there is a lack of extrapulmonary reference, not at the adult level. I think that this is true, that to me, after something else to add at the pulmonary level, I would say that it is an issue that, although we are working on it, not only, that is, at the Catalan level. As I mentioned, there is a group of us who are already very close friends. Of most of the centers. Which are, as we are, partners, and also, there is a friendship. That we dedicate ourselves to these minority diseases and that. And the story is a beautiful one and we collaborate. And we collaborate on projects in agreement. That and at the Spanish level there is the Spanish Society of Pneumology. Has also its interstitial disease area. Which is where these diseases are included. Histiocytosis, there are also initiatives. And there are YY projects, there is contact. That is, to say. For example, among those of us who are dedicated to this at the pulmonary level. If a question arises, there are ways of contacting colleagues. If someone from another autonomous community wants to contact us, they know how to do it. Why, we can contact. And even, my conscientious. And there are also reference in Spain. Yes. You are also in contact with countries in Latin America and with doctors in Latin America in which they exchange opinions with some for cases to receive adults they also consult you. Yes. That at the pulmonary level there is a, let's say, an engagement or a team or reference formed. Yes, that's true. But of course there is like a spectrum more of the general history that we are missing at the European level, not like a kind of more symbiosis between the parties. And I think that at the level of, for example, Spain, it is true that the reference would be a welcome thing to create a kind of reference group of adults of different specialties. Sometimes when I have had doubts from patients who have commented to me, I have commented to colleagues from outside Spain, from Austria, not from Michael. Or to other people who have helped me punctually. And that I had their contact. And I explained the case to them. And they would tell me, but they were out of Spain, and it is true that we would be grateful to have references in Spain for this. Yes. We will work on it. We will try to support as much as we can. Why? It is one of our priorities. To create these groups of why collaborators. Thanks to this platform, we will also be able to open up to a lot of audiences that until now we have not been able to. Sometimes there was also the limitation of language in many cases. And thanks to this platform, we can also open up to other audiences. Okay, those were all my questions, Peter. I finish with my questions.
I just want to quickly thank Sobi for helping to sponsor the implementation of this platform, the Histiocytosis Association and OR Association and Histiocytosis Society.
Thank you all very much for attending.